Welcome to Board Pearls. This is episode 5 of 7 of the ERCP and EUS procedures chapter in the endoscopic procedures module. In this episode, we cover EUS and ERCP in the pancreatitis spectrum before the collections, working up idiopathic recurrent acute pancreatitis, the pancreas divisum trap, and decompressing the chronic dilated duct. Start with the principle that organizes everything here. EUS and ERCP earn their place in pancreatitis only when there is structural disease or stone burden to act on. That matters because every ERCP carries a real risk of post-procedure pancreatitis, and that risk has to be weighed against an expected benefit that is often modest. So the recurring question across these settings is the same. What is actually there to fix, and is fixing it worth the risk of the procedure that fixes it? Take that question to the patient who keeps coming back with pancreatitis and no obvious cause. This is idiopathic recurrent acute pancreatitis, and it is the oldest puzzle in pancreaticobiliary endoscopy. The workup is a search for the etiology that ordinary imaging keeps missing. You take an alcohol and tobacco history, you check calcium and triglycerides, and you get an MRCP to look for pancreas divisum and for an IPMN. You send autoimmune serologies including IgG4. Then comes the highest yield test after MRCP, and it is EUS. The reason EUS sits at the top is mechanistic. The recurring identifiable cause that transabdominal ultrasound cannot see is microlithiasis. These are gallbladder stones so small they fall below the resolution of surface imaging, but they are large enough to slip out and intermittently obstruct at the ampulla. EUS gets a transducer right up against the gallbladder and the distal duct, so it resolves what the surface probe cannot. EUS also screens for occult chronic pancreatitis criteria and for a small mass. That is why it outranks everything except the MRCP that precedes it. Now suppose the standard workup is negative. The tempting next move is ERCP with sphincter of Oddi manometry, on the logic that elevated pancreatic pressures mean a fixed sphincter you can simply cut. Be careful here, because the data do not reward that reflex. Even when baseline pressures are elevated, biliary sphincterotomy produces clinical improvement only about half the time. The reason is that elevated ductal pressure is not one disease. In some patients, it reflects a truly fixed sphincter dysfunction, and there, cutting helps. In others, the same pressure reading reflects functional pain or a different underlying process the sphincterotomy never touches. So the threshold for ERCP in this setting is high. You reserve it for documented multiple recurrences after the non-invasive workup is exhausted, in a patient who understands two things. The expected benefit is modest, and the risk of post-ERCP pancreatitis is elevated in exactly this population. The high-risk prophylaxis stack from earlier in this chapter applies when you do proceed: rectal indomethacin, aggressive lactated ringer hydration, and a prophylactic pancreatic duct stent. Pancreas divisum is where the careful reasoning trap is most instructive, because the textbook reflex was recently overturned. Divisum is a fusion failure in development, so the dominant dorsal duct drains through the small minor papilla, and only the little ventral duct drains through the major papilla. The first thing to fix in your head is the base rate. Divisum is present in roughly 7% of the population, and the vast majority of those people are completely asymptomatic. It is usually an incidental finding, not a cause. A small subset do get recurrent acute pancreatitis, and the old reasoning ran cleanly from there. If the dorsal duct outflow is relatively obstructed at a tight minor papilla, then cutting that papilla should relieve the obstruction. Uncontrolled series seem to support it, with benefit reported in about half of treated patients. That is exactly the kind of logic the boards want you to distrust, because a sham-controlled trial tested minor papilla sphincterotomy against a sham procedure and found no reduction in recurrent pancreatitis. The apparent benefit in the old series was the natural waxing and waning of the disease, not the cut. So current data do not support routine minor papilla sphincterotomy for recurrent pancreatitis and divisum. If it is considered at all, it belongs in carefully selected patients at expert centers, with explicit counseling that the benefit is unproven. And the risk side is worse than usual. The minor papilla is tiny and hard to cannulate, so the post-procedure pancreatitis risk runs higher than for a standard biliary sphincterotomy. Unproven benefit against elevated risk is not a trade you make on reflex. Now move from recurrent attacks to the chronic gland, the patient with long-standing chronic pancreatitis, severe pain, and a dilated main pancreatic duct. The organizing question becomes whether you can decompress that duct endoscopically or whether this gland has moved past what ductwork can fix. The answer is read off the predictors of endotherapy success. The patient who does well has short disease duration and has stopped smoking and drinking. He has a limited stone burden, and he can be brought to complete ductal clearance with the stricture resolved. The mechanism explains why those predictors and not others. Endoscopic stenting and dilation address discrete obstructive lesions you can reach through the duct. So you win when the problem is a focal stricture or a few stones blocking an otherwise drainable system. Where you lose is diffuse calcific parenchymal damage, a gland scarred throughout. There the pain is not coming from a single point of obstruction you can relieve, so decompressing the duct does not help, and the answer turns towards surgical drainage with a pustolateral pancreaticojejunostomy. Note what does not appear in those predictors. The presence or absence of head calcification is not the discriminator. It is disease duration, cessation, stone burden, and whether you can achieve complete clearance. When you do go after the ducts endoscopically, the steps follow from the obstruction physics. You perform a pancreatic sphincterotomy to expose the orifice so instruments pass. You dilate a fibrotic dominant stricture with a 4 to 6 millimeter balloon. You clear stones and you stent to hold patency. The stonework has its own logic. A pancreatic duct stone larger than about 5 millimeters will not exit. The papillary opening after sphincterotomy is mechanically smaller than the stone, so the stone has to be fragmented before it can come out. The fragmentation tool of choice is extracorporeal shockwave lithotripsy, and the reasoning is access. ESWL breaks the stone with shockwaves delivered from outside the body, so it never has to get an instrument up the small, tortuous pancreatic duct to do its work. It achieves complete ductal clearance in roughly 70% of patients, and you then extract the fragments at a follow-up ERCP. When ESWL fails or the stone is impacted, you escalate to pancreatoscopy with electrohydraulic or laser lithotripsy, applying energy under direct vision. That is technically demanding precisely because the duct is small and winding. Mechanical basket lithotripsy is generally avoided for primary clearance because a basket can impact on the stone in that narrow duct and trap itself. Stricture management is where another reflex needs correcting. The intuitive move is to keep adding stents and upsizing over time. Current guidelines say otherwise for a dominant pancreatic duct stricture. You place a single plastic stent of the largest feasible caliber, typically 10 French. You leave it in for about 12 uninterrupted months, exchanging only for symptoms or stent dysfunction. Multiple side-by-side stents are not the first move. They are held in reserve for refractory strictures that have already failed single stent therapy, and head-to-head superiority for the pancreatic duct is not established. So do not teach yourself sequential, multi-stent upsizing as the standard. Standing above all of this is the surgery versus endoscopy decision, and a randomized trial is the anchor. In dilated duct chronic pancreatitis with intractable pain, early surgical drainage with a longitudinal pancreaticojejunostomy outperformed an endoscopy-first strategy for sustained pain relief. So endoscopic therapy is not the default for the painful dilated duct. It is reserved for patients who are not surgical candidates or for selected patients with a discrete obstructive lesion you can decompress in a single session. One more reading task on the chronic gland. When you do an ERCP and the ducts look abnormal, the pattern tells you what kind of disease you are in. Autoimmune pancreatitis shows long irregular strictures of the main pancreatic duct with effacement of the side branches, a narrowed and attenuated duct with multiple skip strictures. Cancer reads differently. Cancer gives you an abrupt cutoff with dilation of the duct upstream of the blockage. Hold those two images side by side. Long, irregular side branches gone points toward autoimmune disease. Abrupt stop with an upstream dilated duct points toward malignancy. In type 1 autoimmune pancreatitis, the IgG4-related form, you often see coexisting biliary strictures and IgG4-related sclerosing cholangitis. That disease is steroid responsive in parallel with the pancreatic process. So the gland side of the spectrum runs on the same discipline throughout. In recurrent attacks, you are searching for a missed cause. In EUS for microlithiasis is the highest yield study, while sphincterotomy in divisum and in idiopathic disease is the reflex the sham-controlled data have humbled. In the chronic gland, you decompress discrete obstructive lesions, a focal stricture or a fragmentable stone, and you read the predictors of success, disease duration and cessation and stone burden rather than head calcification, and you send the diffusely scarred gland and the intractable dilated duct to surgery. The next episode takes the spectrum to its end, the collections the gland leaves behind. The maturation timing that decides when to drain, the pseudoaneurysm check that prevents a catastrophe, the step up from transmural drainage to direct endoscopic necrosectomy, and the carbon dioxide rule that keeps necrosectomy from causing an air embolism. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 5 of 7 of chapter 29, and I'll see you in the next one.